Okay, 1 minute. Thank you, Junior. Okay, good morning and good evenings, all the ICC school friend. I am Dr. P.Y. Cho, and today's I and my colleagues, Dr. Junior Tu and Dr. Wenrong uh, Chang, will co-moderate this webinar. Today, we are so happy to invite Professor Michael Lypka from the Kansas City to give us the special lecture. The title is the 4-1 osteotomy, the complication. And we also have three very important and our good friend panelists invited to come to the panel. The first one is the Professor So from Busan, Korea. Hello, Professor So.
Hello.
And the
Hello.
second one is our Professor Kyotoku from Japan. And the third one is Professor Sarayu from Bangkok, Thailand. So first of all, I would like to invite Dr. Wenrong Chang to give us a brief introduction of the Professor Michael Lypka. So please, Dr. Chan, thank you for your introduction.
Ladies and gentlemen, Dr. Michael Lypka is with us today, and Dr. Michael Lypka is a certified surgeon in plastic surgery and also oromaxillofacial surgery. He earned his medical degree from the University of Southern California and completed his residency in plastic surgery as well as oromaxillofacial surgery. Further on, he pursued a craniofacial fellowship at the Children's Hospital. Currently, as a professor at the University of Kansas, Dr. Lypka is renowned for his exceptional skills in cleft lip and palate repair, orthodontic surgery, and also complex facial reconstructions. With a distinguished reputation in craniofacial surgery, he is deeply committed to advancing the field through education, research, and also patient care. Today, we are inviting him to give us a talk on the prevention of the 4-1 complications. Let's welcome Dr. Lypka.
Here.
Yep.
So I'm going to share my screen here.
Yes, please.
Okay. Everyone's seeing this okay?
Yes, we can see clearly. Thank you.
Okay, good. So yeah, I'm going to be talking about the prevention of Lafort 1 complications. I was giving a talk in Italy on specifically avascular necrosis, and then I was asked to give a talk just more in general. So here I am. So just for all of you, Kansas City, where is that located? That's in the pretty much middle of the United States, and um, it sits right on the border of Missouri and Kansas. So the Missouri River comes through there. And the University of Kansas Medical Center is right on the west side of state line, right on the border of Kansas and Missouri. But Kansas City is a pretty special place to be right now. We've got the Kansas City Chiefs, part-time resident Taylor Swift now here in Kansas City. We have a rising star at the Kansas City Royals, one of the biggest turnarounds in Major League Baseball this year with Bobby Witt Jr. We have a brand new airport that just opened a few years ago. will be one of the host cities for the FIFA World Cup in 2026. So Kansas City is not such a bad place to be. It's great. This is the medical center. The University of Kansas Medical Center has really grown over the last many years. It used to be a small single hospital, and now they've expanded, um, constantly building new hospitals, and it's a very modern medical center. Um, so going back, for me, I'm actually from Canada originally, and I'm from Saskatchewan, which you can see here on the map. So I went to the University of Saskatchewan Dental School, and interestingly, this story on complications starts with this man. Dennis Lanigan was a professor there at the University of Saskatchewan. He was an oral surgeon. He's kind of one of the reasons I went into oral surgery and plastic surgery in the first place. He did a lot of jaw surgery, and it turns out he's sort of the authority on complications in jaw surgery. He sent out questionnaires to multiple surgeons in North America in the 1990s and really came up with a series of articles specifically on complications and pterygomaxillary disjunction. So here I am 30 years later, from that point in time, giving a talk on very similar type problems. From Saskatchewan, I went to Los Angeles and I spent about 8 years there. And I was an oral surgery resident, went to medical school. This is a view from LA County Hospital in East Los Angeles. My director there was Dr. Yamashita in oral surgery. I worked with Dr. Yen, really brilliant orthodontist there. And Dr. Urata, who many of you may know, he's the chief of plastic surgery and oral surgery at the University of Southern California. He was actually a plastic surgery resident when I was an oral surgery resident. And he was kind of one of the reasons why I went into plastic surgery. I did plastic surgery in Houston at the Texas Medical Center and had actually eventually worked with John Tykraber and Jamie Gattino, who were the clinicians really involved in bringing virtual surgical planning to the forefront, and worked with Ernest Cronin, who's the nephew of Thomas Cronin. He's a pretty prominent cleft surgeon. Dr. Cronin was one of the most talented cleft surgeons I've worked with. So a lot of good exposure. And I went back to Los Angeles to the Children's Hospital with Dr. Urata, who was already a faculty at this point in time, and did a fellowship with him there. And this is a view from Children's Hospital Los Angeles. You can see the observatory and the Hollywood sign. So that's my background. So the Le Fort 1 osteotomy, I think we all know what that is. Horizontal osteotomy just above the roots of the teeth. The maxilla can be segmented as well. This is a view of that. From an intraoral approach, you can see the descending palatine vessel here. This is the one thing that stirs up bleeding that we're kind of careful of during the surgery. This is an area where when we're putting the patient back into occlusion in an isolated Le Fort 1, we can get interferences here and we have to be very careful. So an important area. Fixation can be done multiple different ways, but this is fairly standard old school fixation. And this is that patient who had an asymmetry with Le Fort 1, sagittal splits, and genioplasty. Here's another patient who, interestingly, this is a patient of Dr. Arlen Denny, who is now retired from Wisconsin. He wrote many papers on doing Le Fort 3 osteotomies in patients with cleft lip and palate. And this is one of his patients from a long time ago who actually had a Le Fort 3 osteotomy. She had some sort of Le Fort 1 distraction at another institution, eventually moved to Kansas City, but she was treated with a standard Le Fort 1 osteotomy with a large advancement in impaction, genioplasty, and some other procedures later on, but very versatile procedure. You can see this is a fairly big for a Le Fort 1 osteotomy, but can be advanced a significant degree. So we can get some beautiful results with jaw surgery, but not everything's perfect. There can be problems, of course, when we do jaw surgery, and that's what I'm going to be talking about. We don't like to talk about our complications, but I'm going to talk about some of mine and just in more general terms. So with respect to the Le Fort 1 osteotomy, we can have complications intraoperatively. Most commonly would be bleeding. I don't know if any of you have ever experienced nasal tube transection, but it's happened to me one time. You'll know it right away when it happens. Really, it shouldn't happen just if we're protecting the tube when we're doing the osteotomy, but you'll get a large anesthesia all of a sudden can't ventilate, and it's kind of scary when that happens. So, unfavorable fracture of the skull base when it comes to pterygomaxillary disjunction. That seems to be a very popular topic within the complications series in jaw surgery, and we're going to be talking a little bit more about that. Post-operatively, failure of fixation, devitalization of teeth. I'm going to be talking a little bit more specifically about avascular necrosis. And that's a rather feared complication of jaw surgery that thankfully is extremely rare. Paresthesia, anesthesia, oral nasal fistula is possible. And then we can go into a whole series of other complications. So malocclusion, and this is usually due to a technical problem during surgery that goes unrecognized. Non-union, malunion, we'll talk about that a little bit more. And then we can get secondary hemorrhage, vascular complications, carotid cavernous fistula. Relapse is possible more long-term. That's a long-term problem. Unfavorable aesthetic results. We always get some nasal base widening, upper lip thinning. Maybe we've had a bad surgical plan. I'm not going to talk too much about that. And then some of these really unusual complications such as blindness, which hopefully, that's a difficult one to deal with. Intracranial pathology. People have talked about subdural hygromas from rupture of an arachnoid cyst, subarachnoid hemorrhage, cranial nerve palsies. And these are really all related to the theory is we have abnormal forces at the base of the skull getting uncontrolled fracture through the sphenoid bone causing some of these problems. So we're going to talk more about pterygomaxillary disjunction. Other eye problems like epiphora from a corneal abrasion or swelling at Hasner's valves from the drainage of the lacrimal duct within the inferior meatus. Sinusitis problems, eustachian tube dysfunction. So there's a whole series, and Steele and Cope in 2012 in the JOMS kind of gave an exhaustive review of all these small, unusual complications associated with jaw surgery. It's a good reference. But I'm going to focus a little bit more on hemorrhage, those related to pterygomaxillary disjunction, avascular necrosis. I'm going to review a series of mine over the last 10 years and show a case of non-union. So just to review the blood supply to the Lefort 1 osteotomy, it comes from the ascending pharyngeal and the maxillary artery. Now the descending palatine vessel, some people routinely clip this, some people try and maintain it, but that's another blood supply to the maxilla that we know from Bell studies, if this is clipped, that perfusion still remains. There's a transient decrease in blood supply, and then with all the surrounding collateral blood supply, this doesn't seem to be an issue. Remember, in his studies, the upper jaw was separated and then put back really into the same position. What it didn't really tell us, if we put a real significant stretch on the pedicle, what effect that is having on the blood supply. So this is good to keep in mind. So with respect to hemorrhage during the surgery, there's different things that can be done. Just reverse Trendelenburg, having the head slightly up, may reduce bleeding. Hypotensive anesthesia, which is keeping the blood pressure down. I used to be fairly adamant that I'd want to have a lower blood pressure, but I think we have to be careful when we're dealing with this, especially if we're working with a lot of different anesthesiologists. I know where I work, we have the head of anesthesiologist will be in the room at the beginning of the case, and they leave, and you could have a fairly inexperienced person. You're talking to them, please get the blood pressure down a little bit. Blood pressure is going up, and we do our Lefort 1 down fracture as the patient's being stimulated. Then after down fracture, they're not as stimulated as much, and they've been working to get the blood pressure down, and all of a sudden they tank the blood pressure into a place where we're not getting good perfusion of the maxilla. So I'm not so adamant about having a very low blood pressure. I mean, certainly it's helpful, I think, to decrease blood flow or decrease bleeding. But I'd be interested to hear other people's thoughts on that. Certainly just using local anesthetic with epinephrine. TXA is a fairly inexpensive approach to perhaps improving the field. Anecdotally, I think it may help somewhat. Sometimes I find when we use it, it doesn't seem to do much of anything, but I'll review paper on that. Instrumentation, piezoelectric, ultrasonic cutting devices. I've used them in the past. I just find it fairly slow to use them. So I've kind of gone back to using a standard reciprocating saw. Some people like to use these. I think it may be more helpful maybe for some interdental osteotomies, but remember, these generate a fair bit of heat, and while they can be helpful for making these osteotomies, you have to be careful about burning the soft tissue pedicle. Descending palatine vessels, this seems to be the major source of bleeding during surgery. Certainly if they're injured, they have to be clipped. I usually do my best to maintain them if I can. I'd be interested to hear other people's thoughts on that. So here's a sonopet using it for osteotomy, and it's pretty effective in making these cuts, and it can reduce your blood supply, or pardon me, bleeding during the surgery. With respect to TXA, there's a lot of different papers on it, but there's a recent meta-analysis of TXA, and the bottom line with TXA, when all these papers have been reviewed, in general, there's less intraoperative blood loss, about 100 cc's less, reduction in hemoglobin level, drop by 2 points. Anecdotally, there seems to be an improved surgical field visibility. No significant difference in hematocrit, operation duration, or hospital stay after the surgery. I do use it. It's fairly inexpensive and with a low complication rate. So I usually give a dose at the beginning of the surgery, and that's about it. Some people continue it postoperatively. So that's my view on TXA. So now let's talk about more about pterygomaxillary disjunction. So really everything, when we do a Le Fort 1 osteotomy, usually the problems occur in this sphenoid or base of skull region. So the classic is to take an Obergäser chisel, and I know doing my training, when I was a dental student, I went to different institutions at Mass General, at the Mayo Clinic. There's a lot of different variety of how people do that. Some people stick a huge chisel in there and they just start whacking away really hard, and I think that probably is the cause of most of these problems. I don't think that's really necessary. But using a curved chisel and using putting a finger on the back of the pterygoid region and feeling the chisel as it goes through, just with very controlled forces and a sharp chisel, is probably the way to go. But Lanigan, going back to Professor Lanigan, when I was a dental student, had done some work on this, looked in cadavers and used a chisel. And then he used this micro oscillating saw, and he found that there were many more uncontrolled fractures when you used a chisel versus this micro oscillating saw. And it kind of goes in this area. And I was using it for a while. So this would be how that's done. You just put the oscillating saw within the fissure and go through. I find some people that are very large or difficult access, it's sometimes tough to get that saw in position to do that cut. He even found when he did a study, actually, on the right side, he had perfect osteotomies, and on the left side, about 50% was an ideal split just due to positioning of that saw blade. It's very thin, it can bend, and you have to be careful when you're doing that. And then others have come up with, well, why do we need to do an osteotomy through the pterygomaxillary fissure? Why don't we do it just a little anterior to that in the tuberosity area? And Trimble, from the group in Arnhem, interestingly, Dr. Lanigan had spent a year in Arnhem, and obviously that must have been a focus of interest. So they talk about making this osteotomy through the tuberosity. And when I was in Houston, there was a Dr. Terry Taylor who did a lot of jaw surgery. That's mostly what he did. This was his method of doing the pterygomaxillary split, just in front of the fissure. And oftentimes it's described to make often a separate incision in this area to make this osteotomy. And then others now talk about, do you even need to make an osteotomy in that site? David Precious, another Canadian from Halifax, very prominent surgeon, he talks about doing the osteotomy without, or not performing an osteotomy at all and just down fracturing it. And he found that most of the time you actually got a split through the pterygomaxillary fissure. I have not done it this way. I find it to be an area of resistance, but other people have studied that area, and whether you do a split versus not, they found that the forces are not really abnormal in that area. Other people are talking about a minimally invasive Le Fort 1 osteotomy through an anterior approach, taking this Epker chisel and really just driving it back and twisting and allowing to down fracture the maxilla. I think this is an article from Spain. I personally haven't done that. The minimally invasive Le Fort 1 osteotomy to me doesn't make a whole lot of sense. It's an intraoral incision already, but some people. So going back to this, how do you do it? I use a very small sharp curved chisel with controlled forces. I still do a pterygomaxillary split with the chisel, and I'd be interested to hear what other people are doing. But I think we need to be very careful. This is probably the source for most of our major complications in Lefort-1 osteotomy. I'm going to shift to avascular necrosis, and this is a pretty feared complication of jaw surgery. It can be really just loss of some bone between the teeth at the site of an osteotomy site. It's most common in segmental surgery. But you can see in that bottom left picture, it can sometimes just be a little recession of the gingival tissues. And I think if we look very carefully about all our patients who've had this operation, we maybe even see the most subtle form of this, or for instance, even devitalization of teeth, which we don't really check for or typically test for, is quite possible. So this may be happening a little bit more than we actually think. So the reported incidence is less than 1%. And Lanning, again, seems to be the authority on this. He sent out, at this time in the 1990s, he sent out letters to about 8,000 surgeons in the United States. So that's quite an undertaking. And he got quite a few responses back. And he reported these 36 cases of all the surgeons who sent him complications. A little easier to do nowadays with email, of course. So quite an undertaking. But the risk factors for avascular necrosis, certainly in his series, was segmental osteotomies, especially with 3 or even 4-piece osteotomies. And it seemed to be more of a problem with vertical posterior impactions. In the literature, large advancements, again, putting a lot more stretch on the pedicle seems to be more of an issue. I think surgical technique definitely flows into that. Excessive degloving of the maxilla, laceration of palatal or buccal soft tissues. In some cleft patients who've had multiple operations, I've had situations where we make our vestibular incision, you're making that pterygomaxillary split, and then that buccal pedicle, rips all the way back to the pterygoid plate, and it's kind of I've been very concerned in those situations, and those patients really I've never seemed to see a problem in. Other patients who've had really a nice buccal pedicle, which I'm going to show you here, that they don't seem to have a problem. So it's kind of interesting all over the board. Intraoperative hemorrhage has been associated with avascular necrosis. Certainly patients with cleft lip and palate, because of the previous scarring and surgery, can be a problem. Certainly people that smoke and other medical comorbidities. So it's not really clear what specifically in each case it is, but so I reviewed my cases from 2013 to 2023, looking at all osteotomies. Avascular necrosis cases were identified. And the patient diagnoses of most of these patients, I was working at the Children's Hospital here in Kansas City, so most of them were patients with cleft lip and palate or other associated syndromes. So 80% of those patients that I was looking at had cleft or other syndromes, and about 20% of them were just standard dentofacial deformities. So there are 269 patients, 748 osteotomies, and 289 of those were maxillary osteotomies. And this is sort of a breakdown of those cases. 137 were 1-piece, 45 2-piece, and 40 3-piece. Some of them were associated with Lefort-3 osteotomies, premaxillary osteotomies, other segmental osteotomies. So there were 8 patients identified. 3 of those 8 were just some small gingival recession, so not really significant. 5 of the others had some tooth or some bone loss, and there were never any total segment losses, which has been described in the literature. And that was 2.8% of all maxillary osteotomies, so a fairly high rate. And interestingly, there were 2 cases that occurred within a month of each other, really within the last year of the series, which brought the numbers up. But half of the cases occurred during that time period. So in this series, segmental osteotomies, there were 7 of those patients were at risk. Vertical posterior impactions 2. I'm going to show you a case where there was actually a bit of transverse constriction of the upper arch, and this patient had a small loss of gingival soft tissue. Intraoperative hemorrhage, 3 of the patients. 5 of the patients had cleft lip and palate or were syndromic. There was a remote history of smoking or vaping at the time of Lefort-1 osteotomy in 2 of the patients. Interestingly, there was a proportionally a higher percentage of cases in patients without cleft palate or a syndrome. So about up to half of the cases occurred in patients really without a cleft or syndrome. and they only made up 20% of the population, as I talked about earlier. So here's our first case. Let me just review some of the patients I'm talking. This is a patient with cledocranial dysplasia who had a class 3 tendency, and we were going to surgically close the space between the lateral incisors and canines. We used a sonopet to make the cut between the teeth, and we had to remove some bone between the teeth. And those are cases I really don't like to be doing that. You've got a cutaway bone between teeth, and that's where you're putting a little bit more risk of the buccal pedicle. Anyway, she ended up having some bone loss between the lateral incisor and canine. She ended up losing these teeth. Interestingly, I actually saw this patient about 5 years earlier and did exposure of her impacted teeth at the time. I wonder if this had any effect on why that specifically occurred in that area. Possibly previous scarring shouldn't be an issue, but maybe that had a role in why this happened. Here's another patient with a significant asymmetry, really unusual asymmetry that I hadn't seen before. She's got quite a bit of thick buccal bone. And here was the surgical plan, an inverted L osteotomy on the left, segmentation between the lateral incisors and canines. And you can see here we actually had to constrict the arch. And when we're doing that, we're going to put a little bit more stretch on that buccal soft tissue pedicle potentially between those teeth, and in a patient with fairly thick buccal bone in the area as well. She came back to clinic. She had this white area, no real problems noted at surgery. This is a few weeks later. And then that area, we just treated this very conservatively with local debridement in the clinic. And she eventually healed that area reasonably well. This is her result at about 3 months after the surgery. So no loss of teeth in that situation, just some recession. Got away with one there. This is one of the more severe problems we had. This is a class 2 open bite case where we performed segmentation between the lateral incisors and canines. Here's her surgical plan here. It was noted fairly early she had some duskiness of the buccal gingiva fairly early after surgery. We actually took this patient back and did a SPY just to look at perfusion, and it actually looked pretty reasonable at the time, so we didn't really do anything about it. Just with time, she ended up losing the gingiva and some bone on the buccal surface of the teeth. Interestingly, all these occur on the buccal side. It's furthest away from the blood supply. The palatal soft tissues looked perfect. The bones support on the palatal side was totally normal. This is her post-operative result. She actually ended up losing those teeth. Unfortunately, she had too much recession and those teeth were loose, had to be removed. So it's a fairly devastating complication after an elective procedure. This is probably the more concerning one that occurred. This is a class 3 asymmetry case. The patient had isolated cleft of the soft palate, but she had a really small discrepancy, really a small movement. And this was a Lefort-1 osteotomy in one piece without any segmentation. Really nothing abnormal occurred at the time of surgery, no real hypotension noted. And she came back, at a week, and all this buccal gingiva was dusky. And this happened fairly recently. Anyway, she was sent for hyperbaric oxygen treatment. That tends to be the treatment of choice. Whether it really changes the situation ultimately is unclear. But she ended up healing, and she has quite a bit of recession on these teeth. Right now, she's maintaining those teeth, but long term, this is going to be a bit of a problem. So conclusion, segmentation of the maxilla, I think, incurs a higher risk. You saw in that patient without segmentation, so it can happen. You just have to be vigilant and ready for it when it does happen. It was more common, just as common in the patients without cleft lip and palate. So we're always concerned about patients with multi-segment operations and cleft patients, and I've done many of those and not really experienced many problems. I've seen it occur, but these were occurring in patients really without cleft lip and palate commonly. And I feel like I'm pretty good at this operation, pretty efficient, and most of these cases occurred actually fairly recently when I've actually had quite a bit of experience doing the operation. So going on to non-union, This is a fibrous union at the osteotomy site, resulting in mobility of the maxilla. Risk factors associated with this: patients who brux, smokers, patients that have other medical comorbidities. Certainly, a larger magnitude of movement would put you at higher risk when you have less bony contact. Inadequate fixation tends to be a common cause of it. There's a good review in 2023 of 15 cases in over 1,000 patients, and they had 15 patients. Half of those were from the maxilla and half of those in the mandible. I've only experienced this really one time in all the patients I've seen, but it's reported incidence again in the 1% range. And this is the patient of mine who I experienced, and this was a class 3 asymmetry case. This is a transgender patient. Who had a fairly standard Lefort 1 osteotomy without significant complications. Good bony contact. Actually had a bad split on the left side. You could see in the lower that we fixated. It had a buccal cortical fracture that we plated back into position. Sorry, excuse me. She went on to heal fine without any trouble, and this is her. She messaged me about 6 months later. She said, "I think my maxilla is moving," and she sent me this video, and this is what a typical non-union would look like. She didn't really have any pain, but here it is. Take a close look. See what she's biting? It's moving, so it's got this fibrous union to it. This patient was a bruxer, and I think this probably was related to probably the lower jaw surgery. I bet you I didn't have the bite exactly correct. She's probably hitting a little bit harder on one side than the other, and with bruxism caused this non-union. So the treatment for that is to go back and debride all the fibrous tissue. Typically, you would bone graft, and you need to have a better fixation. In this case, we use the custom plates to fixate. The custom fixation is shown to be better fixation, stronger. So she went on to heal and had a good occlusion. So how would I prevent Lefort 1 complications? I think now if I can avoid segmentation, if at all possible, I will. I think that puts you at a higher risk for having problems. It also slows down the operation. I do pterygomaxillary disjunction very carefully. I'd be interested to see how other people do that. I don't get too focused on the blood pressure anymore, trying to get the blood pressure mean down very low. I'm at a reasonable rate, I think is fine. You will need to work very efficiently and quickly, and have a good team around you. And that includes your anesthesiologist, orthodontist. If you're going to make segmental cuts, make sure you have enough space between the teeth to potentially avoid having a problem. So like everything in life, we can probably relate it to golf in some way. And, golf, you think you've got it figured out. You've figured out the key to your swing, and then you don't. All of a sudden, you start hitting some bad shots. And just like in surgery, we think we've have it figured out with our Lefort 1 osteotomy, and then, we're thrown for a loop, have a complication. So, but I love to golf, and just recently, every year we used to go on a golf trip with Dr. Joe Gruss, who would organize a trip. He was a golf fanatic, and of course he passed recently. But Dr. Kent Lynn has taken over. Right here in the bottom picture, we went to South Carolina this year and golf with a lot of different craniofacial surgeons across the United States. So I really want to thank you for your attention today. I'll throw it back to everyone for some questions and discussion.
Thank you so much, Professor Lypka, for your presentation. And thank you for showing us like the possible complications of the Lefort 1 fracture, and also what we should watch out for to avoid them. Now, we're very honored to have friends join us to be panelists for today's event. So the first panelist that I'd like to invite is Dr. Seo-Hyun Jun from Busan University. Professor Seo?
Hello. Thank you for inviting me for this my lovely meeting, ICC, and thank you for the great presentation, Dr. Lypka. It was very impressed about your presentation. Actually, I have two questions about your presentation. So number one is actually I don't have any experience about the the avascular necrosis of the maxilla. So my mentor, Professor Lunjolo, always emphasized please leave the maintain the mucosa attachment as much as possible. And he always, when we do the surgical planning, he also doesn't like the segmentation planning, like ASO. He hoped to avoid that kind of the situation, and I also follow his philosophy. So when I do the surgical planning with my orthodontist, I always prefer just simple report one, osteotomy, without ASO. So it is, I think, important uh, factor to avoid the AVN. But I wonder if for the young surgeon who don't have the enough experience of the especially AVN, how can we what is the early sign of the AVN, and what should we do to reduce or processing of the avascular necrosis? This is my first question.
So I think you wanted to identify it early, and usually you'll see oftentimes you'll see some right away, some duskiness of the gingiva where it looks a little blue, and you can tell there's a problem. And those are patients that you want to send as early for hyperbaric oxygen as you can. Interesting, a lot of these patients, you see them postoperatively in day one in the hospital. It might look a little bluish, but it has perfusion and you don't seem to be too concerned about it. And oftentimes you'll diagnose this in clinic, maybe at a week follow-up. And there's not a whole lot to do, but I think you want to be very conservative. You don't want to be taking these people back and starting to breed away a lot of tissue. I think you want to just let it declare itself, do the hyperbaric oxygen treatment, and then go from there. And then maybe just do a superficial debridement if you need to. But oftentimes you'll lose maybe some, in the minor cases, maybe some buccal bone and some gingiva. But it should heal in slowly on its own. But you don't want to be really aggressive, start pulling teeth, and you could make the situation worse. And I think that's the case in like anything, any type of flap. You don't want to go too crazy about doing anything. You just got to let it declare itself. There's not a whole lot to do. Whether hyperbaric oxygen actually does anything and improves the outcome is unclear. I mean, this is a rare problem that hopefully people don't have a large experience with. But I think that's how it's managed in general, just conservatively, really, and certainly send them for hyperbaric oxygen treatment. Do everything you possibly can to limit the sequelae of it.
Thank you. My next question is about the anesthesia. So usually we perform the OGS on the hypotensive anesthesia. So do you believe that kind of hypotensive situation can make a negative influence about the blood supply to the report one segment?
I mean, the Lafort one, it has a significant blood supply, but if you're segmenting the jaw, and let's say now you've segmented the descending palatine vessels, maybe you've sacrificed those, or that's your routine to do so potentially. You've got this, yeah, if the blood pressure is low, just like any flap, I mean, could that cause a problem? I always wonder, is that, a cause for the problem you have, you know, yeah, I think it certainly could be an issue with related to it. So, and like I said, I think if it's done in a proper manner where it's under control, you may work with the same anesthesia team. Oftentimes, I'll have multiple different people in the room, and I think it's difficult to control that aspect of it. And sometimes the blood pressure is taken way too low sometimes, and I think that can be a problem. So I usually don't get too excited about it. Certainly, if they're hypertensive, there's going to be a lot more bleeding, more just for your surgical field. But I think if you work very quickly, it doesn't seem to be a huge issue. So I don't get too excited about bringing it down because I'm concerned about that, definitely.
Thank you.
Thank you, Professor So. Next, I'd like to invite Professor Sarah Yus from Mahidol University in Bangkok.
Yes. Okay, thank you, Junior. And hello, everyone. I'm Sarah Yut from Bangkok, Thailand. And thank you, Professor Lypka, for the informative lecture. I agree that not so many surgeons love to talk about their complications. So this is a very good lecture, actually. And excuse me for I'm not a Kansas City Chiefs fan. I'm a very strong opponent to the Chiefs because I'm a Niner fan. Okay, so I quite agree with you in most of your talk because of the major complication is the bleeding and the disjunction of the thoracomaxillary junction. So for the bleeding, I usually preserve the descending palatine artery as much as we could. So this is the way that I try to reduce the bleeding. And also the hypotensive anesthesia is quite important. I always ask my anesthesiologist to lower the blood pressure to the mean arterial pressure about 60 to 65. But like you have mentioned that we have to work with several anesthesiologists. So not every one of them love to lower the blood pressure. So I agree that we need a good team with them. And for the disjunction technique, I use the same technique with you. I use the small curved chisel osteotome to feel the junction before I carefully disjunction with the hammer. I always teach my resident to feel the groove, to feel the junction before hit the thoracomaxillary junction. So most of your talk, I totally agree with. So my question is, you have mentioned about the serious complication about the blindness and the skull base fracture. I want to ask that, do you have any experience, personally, to have that kind of complications? Because I never...
Thankfully, no, I haven't had that. In blindness, I think Dr. Chen had written an article on 2 cases of blindness. And I think in that series, one of the patients had some subarachnoid hemorrhage with no apparent base of skull fracture. The other patient did have some skull base fracture, but thankfully I haven't experienced that. That must be quite a devastating complication when that happens. But no, as of yet, no, I haven't experienced that. So I can't say personally.
Oh, thank you. That's all for my comment for now. Thank you.
Thank you, Professor Serayus. Next, I'd like to invite Professor PY for some comments.
Okay, thank you, Junior, and thank you, Michael, for your very great sharing of your experience. Even though I have already learned from it in ECPCA this year in Milan. And I have 2 questions for you. Yes, for the one case that you refer, that is the non-union, the 4-1 osteotomy. So that case is we have the experience to have 2 very similar kind of the cases. After the 2-jaw surgery, and the patients have the delayed, like the floating maxilla. After we keep the very rigid fixation, but still patient shows some the floating maxilla. Patient will show the biting and very loosening of maxilla. So in your experience, how long you will go back to refix and put some bone graft to get a better union for your the mention of these cases is 6 months later. So if in what kind of a scenario in your in your cases, you will do some prevention to prevent the floating maxilla. For some cases, maybe the maxilla extrusion or advancement have some bone gap. You will apply some bone graft, or yes or not. And the second question is, in all your segmental osteotomy for level 1, if the patient still have some might be the necessary expansion, which you apply some Kansas bone for those has some gap, and for augmentation of get a better bone healing afterward. So I would like to meet your experience. Thank you, Michael.
Yeah, for the non-union, sometimes you'll see a patient in a premaxillary osteotomy. I do a fair bit of those in bilateral cleft patients, and you take the splint off at 6 weeks, and it might feel just a little bit loose, and those always seem to tighten up, I find, and heal as the bone graft is healing. So a non-union case, I suppose if you noted it right away, I would give some patients some time. They may get some bone healing. I certainly wouldn't be running back to the operating room immediately. So and interesting, that patient, I didn't even notice it, honestly, at their 6-week follow-up. I thought everything looked good. It's usually a subtle movement, usually. So definitely a delayed case. Bone grafting, when it comes to advancement, in cleft patients or in patients with cleft lip and palate, if it's a fairly large advancement, I do iliac crest bone grafts at the time of jaw surgery. Usually patients without a cleft, unless it's a really huge advancement, I typically don't bone graft those patients just using rigid fixation. I think if you have good bony contact, hopefully that shouldn't be a huge issue. And when we're doing two jaw surgery, we hope the bite force is probably a lot less, probably right after the surgery when we're doing two jaw surgery. If you're doing a maxillary Lefort 1 down graft with interpositional bone graft, and you haven't done lower jaw surgery, I would think that's probably a patient that's going to have a higher risk of having a problem. With respect to segmentation, I remove a lot of bone from the posterior maxillary walls or from the septum, and that's the kind of bone I would pack in between interdental osteotomies in general. But I typically, unless it's a really large expansion, I do not bone graft those typically. But usually, any extra bone I have, I will pack between the interdental osteotomy sites in general.
Okay, thank you, Michael. And I have one curious question that you say in non-cleft cases you have more AVN cases. So can you feedback me what is maybe in your experience to make this happen? Thank you.
It's odd. You'd expect to see more problem in more difficult, challenging cases, and have had them, but a couple of those cases were pretty. I would call them like a chip shot case, fairly standard, simple case, no previous surgery, no scarring. That what was so shocking about that. I didn't do anything differently, I wouldn't say. So it's really difficult. So I think bad things happen sometimes, and it's difficult to explain sometimes. So I can't explain it.
Okay, thank you so much, Michael. You give a very nice lecture. Thank you.
I have a question for when it comes to the descending palatine vessels, do people routinely clip them here? Do people try and maintain them? I, in general, try and maintain them. Of course, sometimes they can be injured during surgery, in which case you have no choice but to clip them. I know there's certain surgeons, a person I previously worked with would always just routinely clip them. And I think patients who've maybe experienced a secondary hemorrhage, a delayed bleed where it caused a problem, those are surgeons who are maybe more apt to just clip it routinely because they don't want to ever experience that again, potentially. So we're always trying to balance, less bleeding at surgery versus decreasing risk of bleeding later versus is it affecting our blood supply? So I'd be interested to hear what everyone's take on that is.
Yeah, maybe what's your opinion?
It's an interesting point because I'm working in university hospital, so we have a system. Even though my patients suffer with some kind of post-operative delayed bleeding, we can't treat it because we have emergency room and we can treat the emergency situation. But some of my friends who work in local clinic, they are so worried about the complication. So some of them just routinely clip the vessel, even they identify the disipaltine vessel and there's no injury, but they prefer the clipping. That make their mentally they get some relax after that. So some people also not just only clipping, put some surgical also because of to prevent the bleeding. I think it depends on the situation. So yes, it's an interesting point.
And how about Professor Sarah Yu?
Yeah, like I have mentioned that I never try to clip them. I always preserve the descending palatine artery. But I have a few cases that I accidentally injured, and it's quite a little bit difficult to stop the bleeding because when you are already injured, the vessel will retract back to the bone,
Mm-hmm.
and we cannot circumferentially clips or ligate them. So in that few cases, I use the surgical to pack around the bone and the pedicle area. And luckily, I have no delay bleeding complication, but I never clip them.
Okay, thank you, So and Sarah Yu. And in our practice in Chang, we hope we can maintain and to keep it intact for all the bilateral descending parting artery. However, once we do some more posterior side, maybe the tubercle removal for a better posterior impaction, and probably some bleeding or tearing of the pedicle sheath. And in that scenario, I would try to maybe to bury it and to totally clamp it to in prevention for maybe the future patient will complain or will show persistent epistaxis. And we have two or very few cases patient might have the epistaxis, nasal bleeding, nonstop. Even the ENT doctor try to using the endoscope to do the stop bleeding, but he cannot find the resource or the source. And we try to using the angiogram to looking for the bleeding source. That is so-called pseudoaneurysm. So somehow we do it for one osteotomy, and you probably guarantee you may not to try damage the descending parting artery. However, it might be in some area or some little procedure, you have some tearing of your pedicle, and the patient will happen delay. It's not immediate after the surgery. It's not probably 7 days after or 10 days after, patient will come back to emergency room to complain persistent nasal bleeding. So it happens. So once you are very guarantee your procedure is very nice and intact of the pedicle, you just keep it intact. However, once you make some trouble, then you have better to totally clamp it or bury it. Yeah, this is our experience.
Okay. Thank you once again to our panelists. So now we'll go on to our Q&A session. So if you have any questions, please raise your question in the chat room. And actually, Professor Lypka, I have a question for you. Regarding the HBO treatment, what's your treatment protocol for that?
Yeah, I specifically don't have a pro. So I work at the University of Kansas. There's one physician who really runs that unit, and that one patient, the female patient that had a non-segmented small Lefort 1 advancement patient, she went for probably I think about 3 weeks of treatment every day. And the other pain with hyperbaric oxygen treatment, they often need to get ear tubes put in, pressure equalization tubes. So that's also a bit of a pain to do that. But I guess it just depends on when you identify it and how the wound is healing. But it's probably about a 2-3 week period of daily dives.
Okay, thank you. Does anyone have any more questions that they would like to ask Professor Lypka? Okay.
I have one more question for Michael. Is that for those AVN cases, the worst the situation is the total teeth lost, and might be a little bit minor. Is probably is the gingiva recession, and I have one case is the patient after the surgery, probably 2 or 3 days later, the teeth discoloration. That means the teeth become darker. Do you have such kind of experience in your practice?
Yeah, I haven't experienced that, but I've heard of that before, where a tooth becoming dark. Maybe you have hemorrhage within the tooth. Whether the tooth is devitalized, it's unclear. But did you find that those teeth were non-vital after?
Yeah, they are still vital, but the color
Yeah,
cannot coming back. Yes.
yeah, it's interesting. Yeah.
Yeah. Okay.
Okay. And Professor So, follow up another question on how do you use the TXA? Do you use infusion or topical application with gauze?
Yeah, so not topical. I just use an IV infusion. Really, at the beginning of the case, the anesthesiologist infuses it. And I think it's relatively cheap. I think I looked at it, it's like $50 maybe for a vial of TXA. So I haven't had experience using it topically. I know some people do use it topically. I mean, I've used it in injection in like during a facelift procedure. A lot of I've done it a few times. I don't know really whether it really makes a huge difference, honestly, but it's pretty low risk. And I typically use it. So, but not topically with the jaw surgery case. I know some people have done that. I don't know if it really makes a huge difference.
So do you just use it one off like prior to the surgery, or have you ever
Right,
had?
right when we right when we start, I usually give it. And then, some people keep an infusion going post-operatively. I don't do that, but
Okay.
suppose you can.
All right, thank you. Once again, we're very honored to have Professor Lypka to come on to our ICC webinar today and to share with us the complications of the 4-1 fracture. And we're very happy that Professor Sol and Professor Sarah Yus join us for some comments. And we're very happy that all of you are here today with us. And actually, 2 weeks late, I mean, a month later, we're gonna have Professor Mark. Let's see. It's John Mark Retrouve, and Dr. Retrouve will speak to us on the AI applications to clinical practice, and that would be on January 12th. So we'll have ICC webinar off for 1 month. So
John Mark, I worked with him here in Kansas City. He was an
yes,
orthodontist at UMKC for a while, so great guy. Yeah.
yeah. So we're very honored to have you, Kansas doctors join us for our ICC webinar, and we're looking forward to his speech a month later as well. So once again, I'd like to everyone to open up their cameras, and we're gonna take a group photo. So we're just gonna try this immersive view that we tried earlier today, and let's see how this works.
Wow, it's different.
It looks very different. All right, I'm gonna
Yeah,
take a photo on
come
count
on,
three. Okay, one,
find your seat. Find your
three,
seat.
smile, and then I'll go on to our next part. Wait, let's see. Oh, actually, I'm gonna quit that because I need to change to a second part, immersive view. Okay, actually, scratch that. I'll take one more photo again. Give me 1 second. Sorry about that. Let's do this again. Okay, 1, 2, 3, cheese. All right, thank you, everyone. So we'll see you on January 12th. And have a happy holiday. Merry Christmas and Happy New Year.
Yeah, happy holidays. Merry Christmas and Happy New Year. Thank you, Michael, for
Thank
spending
you.
your holiday time to be with us. Thank you, so. Thank you, so. You. Thank you, EK. Thank you, Professor Honda. Thank you so much.